Okay, so hello everyone, and very warm welcome to this webinar. We have a great list of speakers today, and you can see them here on the slide. Dr. Louisa Nolan, Professor Marcel Salate, Professor Dr. Lothar Wieler, and Jasper Littmann. I'm Trygve Ottersen, the chair of the IANPHI Europe Network, and also director here at the Norwegian Institute of Public Health, or executive director and responsible for the division of infection control. This webinar is really about a topic that I think it's on in many people's minds and on many people's lips, namely artificial intelligence. And specifically, we want to look at how do AI link and interact with public health and the work of national public health institutes. So that's really the reason why we wanted to have this webinar. We felt in the network and interacting with colleagues across the institutes that many of us are now, if not struggling, at least we are searching for how to best to proceed when it comes to AI and our own work. And of course, it's very much in the mission of the IANPHI European Network then to try to bring together and have webinars like this where we can discuss those questions. So what we have suggested is really that we try to address 3 questions. What are the experiences so far from key actors in public health? What are really the threats and opportunities, both in the long and short term? And what should really national public health institutes like ours do now? Should we sit back and wait, or should we take some kind of particular action to be more upfront, so to speak, in this area? So that's basically what we hope to achieve. To have a discussion about those questions and the topic of AI and public health, and really hear from several perspectives, and then also have a good discussion afterwards involving all of you on the call, hopefully. Sometimes in these webinars we really manage to do that, and I hope this is a topic where we will do. But before we start, just some housekeeping. You should really, everyone on the call should really feel free to use the chat at any time. Share comments, ideas, your own experiences, suggestions, comments, and so forth. And we will try to look and also bring up some of the comments or questions later, or any of the speakers are, of course, free to do that while they are speaking. And then also note, please, that the webinar is being recorded and it will be posted online together with a brief summary. So the plan really is to start with a brief presentation by Jasper, where he tries to lay out at least some of the basic questions and topics for institutes like ours when it comes to AI. And then we will have a small panel where our 3 other speakers will share with us their work and also their perspectives about how we as a public health community should proceed in this space. And finally, we will have what we call a Q&A, but I really hope that it's not just a Q&A, but that you also others will share your perspectives and experiences so far in this field. So let's start with Jasper Littmann. He is a colleague here at the Norwegian Institute of Public Health. He is now acting director for the Department of Method Development and Analytics. He also chairs the Institute's working group on AI, and he has also had a number of other roles here at the Institute, plus a background at the Robert Koch Institute in Berlin. So over to you, Jasper.
Thank you so much, Trygve, and welcome everyone. It's great to be part of this seminar. we thought a little bit about how we could start this off, because obviously this is a huge field, and then our role in this is also quite specific. So rather than giving you some sort of working definition or lots of examples, I thought that what we could do, and take the next slide, please, is that we start with 3 general questions that I think will be relevant for all national institutes of public health, one way or another. I realize that we have different mandates, different functions, different starting points, but I believe that these ought to be relevant for most of us. The first one, quite obvious, really, is how do we make the most of opportunities that AI presents while mitigating risk factors at the same time? The second one is how do we support and enable others or other parts in the healthcare system in using artificial intelligence both effectively and safely? Do we have some sort of regulatory function here? And the third one is how do we think AI will shape the world around us more broadly? And what does that mean for our work and also for our research going forward? Now, in addressing these questions in a broader sense, I think it's sort of important to look at opportunities and risks first. I like to stress the opportunity side because it's easy to sort of just fall into the risk analysis immediately and look at the potential threats. But I think there are some sort of basic, almost infrastructure-related things that we will all start to either work on now or already have been working on. One is quite obvious in relation to large language models, such as ChatGPT or Bard or Bing, where we obviously need to make sure that in handling sensitive data that most of our institutes do, we ensure protection of personal data privacy. At the same time, related to that, given that these models often sort of scour the internet for information, that our advice in the future doesn't violate intellectual property rights, and that we ensure that AI-generated results or the results of AI-assisted decision-making processes do not discriminate or in any way biased. And if they do that, we have to sort of address that. But I think there's also a question about how we structure data going forward. And I think this is probably one of the really big challenges. A lot of us sit on huge data streams and data repositories, but they're not necessarily fit for purpose when it comes to applying AI tools to their analysis of the future. And this is really more sort of data management question that we will have to address before we can really leverage the full effect of many AI applications that already exist. I think there are opportunities within the field of surveillance that are really quite obvious, and I'm sure others will talk about more. I just sort of want to mention them as an example. And I think that the last point is one that really matters for us in terms of organizations that also have a bureaucratic function and limited resources, right? Perhaps not the sexiest part of AI research is of effectiveness and increasing effectiveness in the workplace and the potential that AI assistance offers. But really finding out where we get most bang for our buck, as it were, where we can maximize the effect of AI in the entire sort of spectrum of our workflow, from really sort of basic administrative generalist tasks to quite specific scientific. Next slide, please. I think there's also another function, and that is often the function for public health institutes as a sort of companion and or advisor to other parts of the healthcare system, where if we are, for instance, engaged in sort of quality assurance of different methods, have to play a role in making sure that AI-based tools that are supposed to be rolled out elsewhere are not just effective, but also safe to use, that they're sustainable, that they're reliable in the future, and that we have some sort of following function here where we ensure along the way that risks that may emerge slowly, incrementally over time, are identified early and addressed. Next slide, please. And then there's sort of the larger effect on society, which sort of captures quite a lot, and I think will affect us all sort of quite rapidly now, where we will have to prepare for, but also I think at the same time conduct research into sort of larger societal issues where AI will play a role. One of the really obvious ones is misinformation driven by artificial intelligence, chatbots that flood social media with AI generated content, and reuse that kind of content. There is an added dimension that has been discussed quite extensively already in some publications around the misuse of AI to generate particularly dangerous toxins and pathogens, and in effect sort of reversing many of the processes that we have in drug development, where we try to reduce toxicity and sort of going the other way. But I think the last point is really more one that is about future research, and that is how AI will change the public's health, both in relation to how we work in the future, how we interact with one another, how AI can or cannot be a companion for people who, for instance, are lonely, and at the same time also how loss of agency on the one side that may come as a result of greater implementation of AI might be offset by greater degrees of freedom or more inspiring and challenging, less repetitive work. And here I think we have some baseline to work from for the future. I think these were sort of really just some of the ideas. I'm sure some of the speakers will look at some of these issues in greater detail, but that really sort of serves more as a framework for introduction. Thank you very much.
Thank you very much, Jasper. And at least now all of you saw kind of the range of topics and questions that we have discussed, at least begun to discuss here at the Norwegian Institute of Public Health. And I'm eager to hear afterwards what topics others felt was missing, or perhaps even overrated in terms of importance. Although Jasper didn't really rank the topics and the challenges here. So let's turn to our small panel. We will begin with Marcel Salate. He's a digital epidemiologist working at the interface of health and computer science. And he has been in this field for a long time, really. So it will be really interesting to hear what you really both believe that the latest increase in interest really means, and of course from your perspective what this means for the specific area of public health. So thank you very much for joining, Marcel, and over to you.
Well, thank you, Trygve. Thanks for an invitation. Welcome, everyone. So yes, it's true. I've been in this area for some time. It's always interesting. You know, if you have one leg in computer science and one leg in public health, it's an interesting time, certainly. And we've been using AI for a long time, generally called machine learning, as you all know. The joke is that we call it simply AI if it doesn't work yet. But I think we're here today to talk about the things that actually work. The key thing, of course, that happened in the last 12 months is this enormous success of these large models, or foundational models, or large language models, however you call them. Although they're not only language, as we're now all learning. For those of you who have already tried to use ChatGPT on images, for example. They're just very foundational models that are very, very good at many things at once. And that's really the key new thing here. So, right, a year ago, I would maybe, show a PhD student how to train a model to recognize some text or to make sense of what is being said on social media in a very narrow niche. Now I simply don't have to do that anymore, because it just comes out of the box and it's perfect, and it's close to perfect. It's multilingual, it understands sarcasm. So that field has closed. We don't have to do that anymore. Similar with image recognition. I used to show people how to train a model that could recognize certain things. Could be in a medical context, could be things like food recognition, which I'm very interested in. Again, right, you post now an image to ChatGPT. You ask what it sees, it's close to perfect. It's certainly good enough for any production. And so that also, it's just gone. And so I think that's the key new thing, is that we're now confronted, or in a positive sense, I think mostly, with models that are just very, very broad and general. Even though people are hesitant to talk about so-called artificial general intelligence, but really we're quite close to that. And that's certainly the biggest difference from just a year ago, when we had AI, it was already very good. Think AlphaFold, AlphaGo, all these breakthroughs, but they were just very, very good at one thing. And now we have these new types of models that are good at many, many things. So that's very interesting. You can still fine tune these models to also become good at the thing you're interested in. And so because of that, I think the other smaller types of models will completely go away, and we will only work with foundational models in the future. I think there are some use cases where perhaps a non-general model could make sense. I'm mostly thinking of for security issues. Perhaps in your application, you really don't want the model to be very general at all, but just do one job. But that's probably going to be an exception. Also, maybe, right, for models that you may have on small devices, sensors on bodies and things like that. Of course, you will run into size issues, but I think that's sideshow. I think broadly, we will all use these large foundational models. And when I say large, right, we're now talking about models that have hundreds of billions of parameters and sometimes even trillions of parameters. You can't run them on a local machine. You cannot run them on a personal computer, at least not now. That might change, but you cannot now. And so that's why NVIDIA is now $1 trillion company, because they make the machines that can run these models. But this is likely something that will change in the future as well. So how does that impact AI? Well, maybe the better question is, how does it not? Because I currently have a slightly hard time to understand how it won't impact public health. I mean, in some sense, it's really a new computational interface. It would perhaps be like asking 40 years ago, how will the personal computer impact public health? Pretty much everywhere. Since this is, of course, language, images, video, that's how we humans interact with each other. And AI will be involved in all of these interactions. I'm fairly certain some of you may have AI turned on now to listen in and later give you a very nice summary of all of this. And this is, of course, just the beginning. So as I think Jasper said, of course, one clear area is, since it's going to be in all processes, it's going to be a massive efficiency gain in many ways. And that's, of course, technology as usual, right? That's why we use it, because it makes us do certain things more efficient, which means it opens up time to do other things that we always wanted to do but could never quite deal with. We'll now get to those, and that will, of course, change the field of public health a little bit. But I find it entirely impossible to foresee what exactly is going to happen, again, apart from the things that we already do, in the same way that it was impossible to predict things like Uber and Airbnb when the phones came out. I do want to, though, to finish this up, give one area where I think it's going to be absolutely critical and sort of even a killer app, I think, for public health. And that is in prevention. And as you know, if you now look up, something like AI in health or AI in the medical field, you will mostly see models that are training on hospital data to basically help physicians do what they're already doing, just better, and again, more efficient and so on. And that's all great, don't get me wrong. But it is, of course, I think our core business as public health, at least the way I understand it, is actually not per se treating disease, but preventing it in the first place. And as you, I think, all know, prevention in the past has not gotten enough attention, even though I think public health, of course, has done the lion's share of work, working for prevention. But in the medical system, it's been somewhat a sideshow, unfortunately. And here now, I think we're really seeing an area where interaction with people, where sort of the doctor in your pocket, right, the nurse in your pocket, the health expert in your pocket, the coach in your pocket, that can really be quite a game changer, because you want that expertise to be there when people need it. You ideally don't want to treat diabetes. Of course, once it happens, yes, you want to treat diabetes, but it would be much better to prevent it in the first place. And that's a process of 10, 20 years. And this is not usually where the health expert is involved. And now it can be. And I think there we'll see a great explosion of interesting activities that just weren't possible before. Maybe just to finish up quickly about the concerns, I have two concerns that are quite different from what I think most people have. I'm not super concerned about misuse, although of course I don't like misuse, but I think misuse is just a very human thing. And we've already had misuse on social media, as we've seen in the past 3 years, without a lot of generative AI. So I think this is probably something we can handle with technology, likely. I'm also, strangely perhaps to many, not so worried about bias. I'm actually really worried about human biases. And I think that in general, it will be easier to fix the bias of a machine than to fix bias of humans. And if you're not in agreement with that statement, please send me an email and I'll send you a couple of really interesting papers to demonstrate that. What I am concerned about is that we're now confronted with this and everybody will say, look, you can either have AI or you can have privacy, pick one. You can only have one. And that's a false choice. And again, I don't have the time to go into technical details, but please don't fall for this trap. You can have both AI and privacy. This is entirely possible, but it's perhaps not quite as trivial as many would think. And lastly, I'm worried about speed. We are generally, I think, a bit too slow. And I'm worried that the sort of classical public health processes have taken many years and many decades are too slow for that. And I would really ask those of you who are interested, at least, to think about building new partnerships between public health agencies and academic centers, because I think we can really help each other quite a bit. Thank you very much.
Thank you very much, Marshall. A lot to think about that there. And several have already asked about those papers you mentioned. So perhaps you can post them in the chat or we can add them to the summary after the webinar. So thank you very much. A lot of issues I think we will revisit later, including quite common understanding, I think, of public health, and that is that we are not the one moving the fastest, at least not always. So we need to think about that in this space too. So thank you very much. The next panelist is Louisa Nolan. And she is head of public health data science at the Public Health Wales, and where she, among many things, she shares the AI for health and social care in Wales working group. So she comes into this area, I think, from multiple angles. So over to you, Louisa.
Thank you very much. I agree with what Marcel just said about bias and human bias. That's really interesting. So when I was thinking about what I was going to say today, I thought, well, you know, large language models, what I'll do is I'll ask ChatGPT to write my slides. So I said, hello, please, could you write, because you always have to say please, because you never know when they're going to become our masters. Please, could you write an 8-minute presentation for me on the risks, challenges and opportunities for AI in public health? This is not that presentation. It was really interesting what it came back with. On the one hand, it was quite boring. And on the other hand, it was really interesting to see what the summary of English language web content on AI for public health was. There was a lot of stuff, a lot of pictures about how great AI is and what the opportunities are. There was a lot of, you know, high-level comments about risks, but there wasn't much that really spoke to me about why, if AI is so great, why we're not doing more of it. And I'm really interested to hear what other countries and other public health systems' views are on this. So what I wanted to talk about really was a bit about the way AI can help us in public health, but also about why, if AI is this great opportunity, why we haven't done more of it, and why we need to do something now to address the risks and barriers. We can't just wait. And then finally, a bit about what we're doing in Wales to address some of these issues. So we start really with what AI can do for us, and you've already heard some things. So there's things like things we know about, predictive analysis. Epidemiology has been doing this for a while. We're looking at doing disease projections and scenario modeling. This is all good stuff. Things around surveillance and outbreak detection. There was the famous Google Trends flu outbreaks. That was quite a while ago now, probably getting on for a decade ago. Things like risk stratification, segmentation, so understanding the characteristics of, for example, smokers, people with obesity, so that we can target messages. And we're just really beginning to get into NLP and coding to reduce the burden on that. Those things perhaps are less new, less risky. Pedantically, those are things that perhaps in the past we may have called data science, not AI, and even before data science was invented, we may have just called it statistics. But leaving aside the pedantry, there's a whole load of new stuff that's happening, the stuff that hits the headlines. So things like diagnostics. So can we reduce the processing time and improve outcomes, free up specialist resource for the more tricky decisions by building AI into analysing images, for example? Something we're quite interested in is around wearables. So how do we keep people safe in their home? How do we think about their movement and physical activity? It's a really interesting example of a pilot where people were given wearables and then their friends and family, who were permitted to, had access to the data from that, so that they could see whether the people were moving or not, and perhaps give them a bit of a nudge if they hadn't moved much. And one person hadn't moved very much. The family member came round, he was suffering from depression, they managed to pick it up really early and there was a good outcome. These things are amazing. And then we go to personalised health, so not stuff that we're doing ourselves, but it's a growing field in the private sector, from things like Fitbits, sleep apps, mental health apps, all those things that can help keep us healthy and help do the prevention side of things. And then the generative AI. We've heard from both Marcel and Jasper about this. I think we're probably all agreed at this point that generative AI, we're not going to be writing papers using generative AI. It tends to make stuff up, but there's some really useful and interesting things that we can do for public health. Things like summarizing papers or creating tables from text, being a coding assistant. This is great. This is transformational. It can take all the pain out of having to look things up. And yes, I think in the case of asking it to write things from scratch, not only that it makes things up, but also it's not always the most engaging answers either. So this is all great. We can see how the future can be better. We can do more around prevention. We can have a more personalised approach to people's health. We can help planning. We can manage issues early, reduce workloads. So why aren't we doing more of it? So I picked out a few things to think about. There are more. I mean, this is a topic that I won't, but I could talk for quite a long time. So the first thing is about trust, not just trust of the public, but the trust of us. We know there's lots of risks. If we have a good ethical regulatory governance framework, that gives us the trust in that what we do. We've been through all those things. We've talked about bias. We understand the bias. We've decided whether we care about it or not. We've talked about whether it's an ethical use of data. We go through that process. We can then feel confident in using AI. So there's been a lot of work done, both UK and international, around things like ethical frameworks, algorithmic transparency, AI standards. So how do we make this into part of the process when we think about adopting AI? I do have a question about algorithmic transparency. I don't know how much users need to know about how it works. I mean, I don't know how my phone works, but I'm still quite happy to use it. It's more about understanding what the implications are for them and what they can do to challenge it if they have a problem with it. It's a big thing about capacity. So this is not just skills. It's already been mentioned, Jasper already mentioned about our data flows, our data sources and digital. So getting our pipelines right so that we can build AI on top of it. This is perhaps one of the most important things. We know that a lot of AI tools are invented in academia with tidy data in research environments. Moving that from a research environment into a real environment is difficult. Something around skills, not just the ability to code or write AI data science projects, but also to understand the risks and opportunities and how we go from those pilots and those prototypes into deployment. So often this can be a quite transformational change. So we need to think about what the user needs are, whether that's staff or patients or public, their experience. And for that, we need not just those technical skills, but things like delivery management, procurement that allows us to build those effective partnerships. So we're working together with other people with different knowledge that we have, know what questions to ask, things around user engagement. How does it work in the workflow? And for us, I think that's where we can build our skills, and that will help with adopting more useful AI. So then we get to the question, prototyping is easy, scale up is hard. I'm not saying doing a research project is easy, but it's very different from doing something in a research environment to building it actually in real life so that staff are using it. So we come back to the user needs. We need to make sure that what we build is user-driven. Where do we get the most benefit? How are people going to use it? How are people going to engage with it? And that's a set of skills that's different from research, different from even public health. The biggest need, the most useful thing might not be the most interesting research case. So I'm not saying don't work with academia. It's always useful to work with academia, but there's a gap there as well that we need to address. And the last bit is around workforce planning. So probably not a reason we're not doing it at the moment, but it's something that we need to think about. If this is going to be transformational, if we're going to take some of the routine manual things out of people's work, we're going to build those digital and data systems to build the AI on top of, we need to think about the skills that people need and what the shape of the workforce looks like in the future. So the last bit, what are we doing in Wales? We want to create this safe, ethical, responsible framework for AI in health and social care in Wales. So we have the working group that I chair on that. Public health institutes are not huge. Working across the sector in Wales means that we can work together on solving similar problems. It's about building that trust in AI and thinking about how we exploit the opportunities confidently. That across that whole health and social care system. We're a small country. We don't need to reinvent the wheel. We're interested in principle of adopting and adapting what's been done before. We are a nice size to try new stuff out there. So some of our priorities for this, for AI in health and social care in Wales: safe and ethical AI, make use of what's there, making sure that we've got the clear guide. So someone comes, I want to do this AI thing, or I want to get hold of some AI. What do they do? Where do they go? What are the steps they have to go through? What's the regulation? What's the ethical framework? So, for example, we're looking to adopt the ethical framework from the Alan Turing Institute, the UK government, but adapted for Wales's particular situation. Same with algorithmic transparency. We're thinking about setting up a register of AI devices, partly for auditing, partly so that people can see transparency, people can see what's going on. I think they already have one in Scotland and also Amsterdam. Really deep understanding of user needs and barriers. So we're doing a deep dive into what those specific barriers are. If we're asking people that they need to get expertise from some person, does that person actually exist? Do we have the skills? What's already available? What could we roll out at scale, and how can we overcome the barriers to that rolling out at scale? That's probably around radiology and pathology. What does the workflow look like? Not just the technology, not just the algorithm, but the whole workflow look like. And then finally, what does the ecosystem look like? So what I mean by that is who is available to help people on this journey, to offer advice, whether it's technical, whether it's ethical, whether it's about data, whether it's inspirational in the art of the possible. Who are the people or the institutions that can help with that? And who do we need to partner with? That will almost certainly be academia. We can have effective partnerships with the private sector, I think, as well. But how do we fill those gaps in our own skills and knowledge so that we're working effectively? So we're a small country, doesn't mean we lack ambition. It's quite exciting to be here. We're really keen to learn from others' experience and to share what we learn so that we can all use AI ultimately to improve people's health and well-being, but to do it in a safe and ethical way.
Thank you very much, Louisa. And of course, so many things again that we can revisit in the discussion afterwards. But one thing that I find really interesting, and that's when you start to discuss and talk about the workforce and the competence we need. Because of course, in the face of uncertainty that many of us feel, and Marshall described it really elegantly, what, you know, how hard it is to say at this moment what will be the main areas, except with some exceptions. Perhaps one of the main things we can do as public health institutes is really to at least start to build the right or generic enough competence, so as kind of preparedness for whatever comes. So maybe we could also discuss the competence and the workforce requirements later on. So thank you very much. The last but not least, the panelist in our small panel is Professor Dr. Lothar, and he is now at the plus, let me say, at the Hasso-Plattner Institute, where he's the speaker of the new digital health cluster, and he has been in that role since April. And before that, he was the president of Robert Koch Institute, as many of you in this call know, for more than 8 years. And Arki was also one of those that really, I think, were the front runner in terms of putting emphasis on AI. So I think at least those 2 roles, Lothar, and probably many more, is a great platform for you to help us better understand how we should proceed and how to think about the phase we are in right now. So thank you, and over to you.
Yeah, thank you. So first of all, thanks so much for having me here. And it's hard for me, of course, after these brilliant 3 interventions, to add something to this, because absolutely I echo everything what has been said. The only issue that I have a little bit more, or I'm a little bit more afraid of, is misuse of this perhaps than Marcel. But in general and in principle, what you said is absolutely the issue. So the issue is not whether public health has the decision to use AI or not, but the issue is how can we implement it? How can we implement it strategically? How can we implement it in a way that that we don't lose trust? That's a very, very big issue, and an issue that is particularly always mentioned here in Germany is this privacy versus efficiency versus using new tools. It's due to the history of Germany. This privacy issue is outstanding, and the first thing I want to say is we can never guarantee 100% safety and security, and we can never be able to provide 100% efficient tools that will do their job. So the first thing we have to do is a sound risk communication, a sound, transparent, open communication. What can we do? What have we to take into our minds, and what hurdles do we have to take? The second thing is, if you look about National Public Health Institute, and now I'm speaking just what basically has been done during my time at the Robert Koch Institute, and Marcel Salaté was actually a part of this development. The big issue is, to be very frank here, to convince conservative epidemiologists, among others, in National Public Health Institutes of the efficiency, the usability of these particular tools, because you have to change the business model. And this transformation has to come out of the public health institutes. They have to do it by themselves. They have to understand the pros and cons of these possibilities. And if they are not the drivers of this development, how can they shape the development? And this is some of my most important concerns, that national public health institutes will stay away for too long, will not take enough opportunities, and will not be on the spot, because it's so obvious that we can use these technologies. And so I just line out what we have done at the Robert Koch Institute. The first issue was raising attention. we set up a seminar. It had been called Digital Epidemiology, and Marcel provided a talk to this to just open the eyes of the possibilities. The second thing is that we're building up networks. We need to build up networks with people who have the competence to do it. But we have to build up these networks as public health people who always think about implementation. Yeah? The implementation issue has to be driven in each and every of these projects. And therefore, we should always have in mind that this can be implemented only if the users are part of the project that we are doing. Public health implementation is of such a huge importance. Therefore, it's so nice that these large language models are basically very easily to adapt in many ways, for example. The third thing that you could do is, I was successful in that I launched a Center for Artificial Intelligence and Public Health inside the Robert Koch Institute as a on-top budget, basically. So we were lucky enough, a process that cost me 3 years roughly, but we were lucky enough that the government understood that AI is also a means that is very much needed on public health. And the issue here is, and Marcel also touched this, mostly people looking at healthcare when they talk about AI. And the most of the usability and most of the issues that you see when you're talking to scientists is healthcare and a very, very focused healthcare. And therefore, we have to shift gear here in the discussions to make clear that, and in particular, I also echo this, prevention and health promotion. That's the area where public health is very important. That's the area where these tools can help us. So if you have the chance to bring in this competence by yourself, you should have a certain amount of competence. You have to have this to bring it together, but you have to have partners. And what the Robert Koch Institute also did, after they had been able, we have been able to set up this department on artificial intelligence for public health. We also hooked up with a network, the European, ELIS, it's called, the Network for European Laboratory for I can't read my own names, but the system is a system that we hooked up with other universities to find solutions and find scientific partners, particularly in public health. So if you have set up, if you have a mind change in your institution, a clear understanding that public health causes changes, but it will help us to be more efficient, then you have to deal with partners from outside so that your own people really profit from these developments. And the last step that I want to mention here as a concrete step, there has been built up a bottom-up initiative. It's now called the Global Initiative AI for Health. And this has been set up, I have to say, this is luckily enough, this has been set up in particular by a German colleague from the Heinrich Hertz Institute, Thomas Wiegand is his name. And this initiative has all the time been supported by WHO and ITU, the International Telecommunication Union, so 2 UN organizations. And this is a bottom-up initiative where basically with minimal funding from the Botnar Foundation, they are really finding use cases. And they set up an ethical framework. It's published under the WHO. You can find it on WHO website. And they are basically looking for people who work with them, and they are looking for people that are willing to share their data. It's all open sources, and all these different examples can be watched and can be seen. And some partners of National Public Health Institute, like from Kenya, are already enrolled in this initiative. And I think that it would be great if, in particular, IANPHI could really foster a way here, develop a policy and a strategy to be part of these initiatives, because we can exchange a lot of information and we can exchange a lot of knowledge. And then if you look at application of AI, I always recall the essential public health functions or operations. And if you go into these different areas, you would see that in each and every of these areas, be it the 12 functions or the 10 operations, you will see each and every field, you see particular fields where you can apply artificial intelligence for the good, to be more efficient, to be more precise. And as Marcel also told us, and Jasper, we can really put our workforce in other things, and then we should particularly put the workforce in implementation of prevention and health promotion issues. So for me, it's obvious that we have to, society will anyway be changed by AI, and national public health institutes, they also have to change with this and grow with this. So we all should be very keen to invest in AI and lead by example in the way that we really bring best practice on the market and share these best practice examples with colleagues from our international public health institutions, and do this always together with WHO. You know, perhaps Marcel, you perhaps don't know this, but we have been able to form a memorandum of understanding, the IANPHI or the National Public Health Institutes with WHO. And I think we should stay in this framework, and we should really define in which areas we particularly use AI in prevention and health promotion in particular. So that's from my side.
Thank you very much, Lothar. Just to pick up on one point that I think many of us have experienced, that health versus healthcare. I at least have went to 3, 4 maybe seminars on AI and health, and what they are really about is AI and healthcare. It's only about what happens within the hospital. And of course, there is a lot of important applications beyond that, as we have touched on. And I think that's one of the areas where institute like ours and also IANPHI can really contribute. Healthcare, obviously important, but we need to go broader than that when we talk about AI and health. So just to say that very much resonated with the discussions I have seen elsewhere as well.
Just to exactly, and we have to recognize this. You know, this is really important. We have to make the point that we also need it in public health. And just 2 of the projects in this global initiative. One is about women in Kenya who are pregnant, and whenever they experience whatever problem, they have developed a chatbot so that they can talk to this chatbot, and then the chatbot will help them to visit a doctor or not. Yeah, and this is a simple example in principle, but there are so many examples. Another example is ramping up screening for cervical cancer. Yeah, with this is secondary prevention with this tools. You have only a very limited amount of medical doctors that can screen these slides, but within a tool that has been developed under GI AI for Health, you directly speed it up 10 times, because all the negative tools samples are very, very easily identified, and then the doctors can concentrate on those who are critical or positive. Yeah? So there are many issues that are in the preventive area that we can really do a lot, and we would really gain efficiency. And therefore, I think this GI initiative is very important, because it's all open source, it's all very transparent, and this is how we build up trust, because these projects are running in various countries. That's very, very important.
No, thank you very much, Lothar, and also for the suggestions, of course, about how IANPHI can contribute in this space too, and perhaps link with the initiative you mentioned. Now we are done with interventions from the panel, and we move to just a broad discussion. What I really hope is that anyone else on the call or in the meeting, if any of you will share your experiences, user cases, challenges, perspectives that really haven't been covered, or any questions, of course, to the panelists. And I can only see one question so far. So while letting you some more space to either raise your hand or put in a question, I will just make one very general question to the panelists, because IANPHI, right, is often about either supporting the establishment of national public health institutes or the development. If we, in that spirit, to the three of you, if there is a director of an institute that I have listened to this call and they were kind of skeptical about AI, at least whether we should do so much the next 2 years, because yeah, it's difficult. It probably will happen, but let's wait and see. We will get something more easily applicable in 2 years' time. Now, after listening to you, right, they agree with what you summarized, Lothar, that it's not whether, it's really about how, and it's just to really start in order to get this right and to harness the benefits as soon as possible. But if one is so convinced, but still have a small budget, what will you recommend that director to do if they are allowed to initiate one project and employ 2 new people? Where should they start? And then, with such a generic question, perhaps more specific ones will turn up in the chat. May I challenge you on that? Marcel first, if we follow that order.
Sure. Well, if somebody told me I have resources for 2 people, I would say make that time available to your existing staff to upskill on digital skills and AI, because the staff you already have is probably very good. That's why I hired them in the first place. What they want and need is they need the upskilling, right, for more digital skills from wherever they are. Some are already advanced, they can go further. Some are at the very basics, they can go even they can start. But that, I think, is what I would do, rather than just do a sort of demo project. I would rather make sure that everyone's on board, sort of echoing what Lothar said, right, about making sure everybody's on board, everybody has trust in this.
Great, thank you very much. Louisa, what would you do if your institution wasn't that developed or so far in the space?
I'm happy to take the money and the people anyway. I think 2 things. So the first is that regardless of whether we want to do AI, we do need to be paying attention to it. We need to understand what the risks of generative models are and make sure that our staff understand that you can't be putting personally identifiable data into these models, because then it doesn't belong to you anymore. So part of it would be making sure that we've got the guidance and governance right for where we are at the moment. And I don't think that's something that we can wait for. Particularly if we're looking at bringing AI into screening or something more diagnostic. The other thing I would do would be to go, well, I don't know the answer to this. And what do you do when you don't know an answer? You do a discovery. So you bring in some kind of user engagement, user needs specialist to go talk to your team, look at where the pressure points are, and decide where you would put your money and where the best return would be, rather than actually doing something. And what you'd need. So not just what that project would be, but what skills and people and tools you would need in order to actually deliver that project.
Great, thank you very much. And Lothar, you
Yeah,
probably you have almost done this, I guess, 3 years or so.
But I mean, the issue is really, I'm absolutely convinced that you can only be successful if you convince your own people in your institution. So these 2 people really should, there may be a certain topic that has to be solved, and 1 or 2 people in the institution have this topic on their desk, and you, together with these people, you will be able to to improve and to solve this problem. And I think this is the most important issue. The way we were very lucky at the Robert Koch Institute, because what we did was we had more resources from the start. So we initiated networking in the institution so that each and every of these departments or whatever had to file some ideas where their regular work they are doing, how could it be basically speeded up or made more efficient by working with this particular tools. And whether predictive modeling is an issue, diagnostic is an issue, infodemic management is an issue, particularly after this COVID pandemic. We all understood that this is something that you could more easily debunk, you could more easily react to it, at least you could more easily detect reaction like this, and you could change your communication in this regard. Something that, for example, at the Robert Koch Institute was interesting is, I mean, we had thousands of documents on our website. Nobody can read these. I mean, we knew these before, but now imagine you had a chatbot that can read with these particular documents and get knowledge about what to do in a crisis or so ever. So it's really, there must be use cases that come out of your own institution, I think, because otherwise it's sometimes hard to convince people because they have to change. Some of them will have to change their job profile, no? And there is the fear, for example, that you lose work capacity, but actually we all don't have enough work capacity. So I will always argue we win working capacity, but they have to understand this by an example. And because I see the question here about the resources. So the idea in this GI AI for Health project is so that basically algorithms are developed, and of course they must have to be trained by local data to get rid of these bias problems. And it is very clear that some of the technology has to be supported to be set up also by funders. I mean, that's clear. And I think again that the IANPHI, that's why I brought IANPHI into this GI initiative, because they before I joined, they also were only concentrating on healthcare, yeah. But now they're also looking at public health, at prevention issues. And I think again, trusted national public health institutes could be some key players, because many of those have data that can be used for training, but they should be, of course, then available for training. And this is just another issue that you have to solve with your people and with the legislation in your country. But they have to be trained in these particular countries where the data have been generated. No?
Thank you very much. And now there is several questions coming up in the chat, and just before we start to address them, just so all of you on the call know, you are very much welcome also to raise your hand and speak and share your experiences. This is, in the spirit of IANPHI, is really just about learning from each other and trying to move more efficiently from here. So some of the questions is really about two big topics, inequality and climate. And to start with the big ones in a way, do any of you want to comment on those? Marcel, you already, I think, comment on the question about green AI and how to proceed. But both climate, but also inequality. That's one of, at least I think, institute like ours like to see ourselves as the defenders of equity. How can we play that role in this space, really?
Yeah, if I can maybe just say a word, because I think this notion about bias struck a chord. I can see many people are asking for the papers, and we'll definitely send them around. I mean, maybe I can make the point a bit more specific. So, right, because it goes also towards health inequities. Of course, the main concern is that you have a health inequity in the system, and now you're simply training an AI model that is on the data that you have, because that's what you have to do, and it picks up this equity and purports it, right, continues it, perhaps even makes it worse. And so this is, of course, exactly where this point, comes back. It's you if you have a way to properly measure the bias, then you have a chance to fix it. And this, of course, goes also back to Lothar's statement. I know this focus group very well, and I think it's great. I was there in the early days. I kind of left because I was a bit frustrated with the speed at which things are developing, but I'm great to see that things are moving forward quickly. And of course, that was exactly the notion. The notion was to say, what sort of benchmarks can we develop, right? So that everyone can say, hey, this type of algorithm here works really well and is bias free. Because when you have that benchmark and you say, what should this outcome be, right? Then you can really quickly measure and assess biases. And once you see these biases, you can, in the machine at least, very quickly fix it. And that's the way to do it. You can't just train a model on data and say, now it's the model who does it, and not expect that it will continue exactly the biases and equities you have in the system. You have to have a kind of a benchmark to measure those. But now that you know it, in the model, right, you can specifically go and fix it, whereas it's much harder to do in society.
I think also I was really struck with your point about human biases as well. So can we actually measure the human biases, and understanding that is part of that journey to getting people to take on AI and believe that it's in some circumstances better than a human.
Yes, thank you. So beyond bias, I guess when it comes to inequality, just to mention, I don't know, Sunita, if you want to elaborate, but I take it that you also point to how countries can support each other, where we expect that the uptake and development in this space will be quite different, but perhaps also between population groups. And at least some of our institutes are we often take the role as trying to equalize as much as we can the health competency or the ability to navigate and make use of health improving tools. And I guess that might also be an area, depending on our mandate, of course, where other actors might not actually be so active. So it might be a space for us to help too. Then we have some other questions. You can pick one if you want, any of the panelists, or I can point to one. One from Erna here is, I read somewhere that the current large players are the ones that have enough computer power, access to data, and investment to run large language models. In the future, smaller rivals may appear on the market that might be more specific using smaller models. How do the panel members see this? And if it were to happen, how can we assure the quality? And I think several of you touched on this. Do anyone want to elaborate? I guess it's hard even with the large language models, but here we envision a scenario with even more players and models, I guess, and even harder to navigate.
I think the question of quality assurance is really important. And just because they're large, unless the people who produce them are transparent about what they're doing and we know how they work, then, we don't just trust them because they're large necessarily. I think not just for public health, but there's a strong case for more open source, which allows us to check the quality, multiple people to check the quality, to feedback and change. And I'd be a big advocate of more open source for some of these models, rather than just allowing it to be only in the private sector.
Yeah, I mean, it's an obvious good question, and let's, obviously, Marcel, you touched upon this. The process is slow and whatsoever. But I mean, I also think the open sources is the key issue here. And this is, for example, in this GI AI for Health, this is one of the prerequisites when you're working there. It's at least I don't have any alternative idea how you can manage this, no? And people from the different countries have to get involved and take it up. It's those who are willing to do it, no?
No, that's certainly true. But I do think there's an intermediary situation, right? I mean, we often talk about, okay, there's industry, they can do everything very fast. And there's WHO, where everything has to be very consensus-based and slow and so on. And but I think there's an intermediary area where there are not enough players. And I imagine this really as these sort of a kind of coalition of the willing, if you forgive the term, of public health agencies and academic centers, right? And you mentioned ELIS, which could perhaps be a good vehicle, that get together and say, okay, right, speed is of the issue. What are the key issues that we want to tackle? What are the benchmarks we can develop very quickly and with the data that's available in our respective countries, right? The proof of principle, low-hanging fruits, and then quickly demonstrate that this works. I'm sure the WHO and this group would actually be quite happy then to embrace these benchmarks and say, well, we'd love to bring those into the WHO sphere. We'll take a little bit more time because everybody has to be on board. But thank you for already establishing this. So I think there's a middle ground here that's not currently served.
Thank you. And then we can take some few more questions before we start to round up. Here's a question from Simon Packer. A lot of health data is poor quality, and is that a concern to those working in AI? Should we invest in better data before investing in AI? And he's suggesting that that might not be the most popular funding opportunity for funders. So what do you think? Some people disagree on the topic of the attractiveness of data, but what do you think?
Data's sexy, of course it's sexy. We can't do anything without good data. And actually, part of what I hope for is that the attention on AI and that kind of senior, oh, look at the shiny thing, helps us to make the case for better data collection. Because whether it's AI or just doing better with data, which underpins all of this, that's fundamental.
Yeah, I would also say from a technical perspective, right? I don't know how many times I had to hear garbage in, garbage out. And now, right, we're seeing, you know, these large language models, ChatGPT and so on, they were trained on the internet, right? Which I would say, right, we all agree is probably 98% garbage. But it's garbage in a scientific sense. It's great in the sense that, well, it's language, it's the way people interact, right? Even if we say, okay, scientifically, it makes absolutely no sense. And just, right, showing that actually what you think is garbage is not necessarily garbage, because you can derive many things that are going to be quite useful for these large models. We don't understand how this works at the moment. But I would say unless the data is just entirely fabricated and specifically designed to mislead, even data that's perhaps not so top-notch quality can be very, very useful to train AI models.
Yeah, I was about to, even before you said that, Marshall, to challenge you, or at least put that up, because it seems to be a more complicated messaging these times, because at the one side, we still want to underscore that with better data sources, better data, we will get even more out of these models. But on the other side, the beauty of these models is that they get more out of what we have, and even what previously or in other contexts would be garbage, or at least low quality. So it's a bit more tricky today, I think, to communicate. But Louisa, you had a point.
Yeah, I agree. And I think despite what I said, I mean, we should be ambitious for better data collection. But having said that, I think there is a big gap in research likes to work on perfect data. Real world data isn't perfect. It's messy, it's incomplete. There's a big gap, there's a big research area, I think, of making AI, not even AI, just in improving the poorer quality data. And once you can start linking data using predictive approaches, you can perhaps improve the data that you've got. You can make your AI work on that. There's a big area. But I don't think that should stop us trying to improve our data collection.
Thank you very much. And I think we're already close to time, actually, and we need to round up. Just to say again that I will leave you with 30 seconds for any final remarks. But just to say that the really idea with this webinar, right, was to quite early in the phase for many of us to share some ideas and make it somewhat more easy to go back and continue what I think we all agree is at the very start or quite early in the journey. So before we round up, then I will invite you, each of you, just to allow you at least to have some final remarks, and I will not try to summarize in the end. Marshall, please.
Sure. Maybe just two small remarks. Just so that nobody gets the idea that they need to create large language models from scratch. I think that's very unrealistic, in the same way that, you know, you would not expect the public health agency to develop a search engine or an operating system. In the same way, right, nobody's going to will have the capacity to train these large language models. Instead, what you do is you fine-tune them with the data that you have to your purpose. And so there it's very helpful to have high quality data, just so that people don't feel completely hopeless about this. Generally, I would just reiterate the fact that I think we have an open gap of a coalition of the willing, where public health agencies and willing academic centers could really move the needle quite significantly between those extreme poles of global health organizations and industry. And if perhaps IANPHI could play a role in that, that would be fantastic, or anyone else who's interested in taking a lead there.
Thank you very much. And Louisa?
Thanks. I think we can't not do anything, because we have to pay attention to the risks, if nothing else, and the opportunities are great. There's a lot to do, but working together, and not just across public health systems, but across other sectors as well. We don't have to reinvent the wheel. There's been a lot of work done about ethics and frameworks and transparency. We can build on that. And the same as with the large language models, we don't have to invent it all ourselves.
Great. Thank you. And Lothar?
Yeah, I'm so glad that I had the opportunity to be part of IANPHI for so many years now, and I very, very much appreciate IANPHI, and I think it should take an active role here in moving ahead. And you know, I left the Public Health Institute and went to a university. Why did I do this? Because here we have counted 23 professorships that are working on all different kinds of digital tools, AI specialists, cybersecurity specialists, whatsoever. So I want to bring this also back to the National Public Health Institute. We need to work together here, and I as a person, I'm one person that tries to link these different worlds with each other, because I'm absolute utmost believer that this is the way to do it. It's all about trust. It's really so much about trust and knowing each other and working together. So let's use the network power of IANPHI and support each other. There is a gap, and the National Public Health Institute has the spirit. And I also want to again touch this. National Public Health Institute have a keen eye on health equity, and also the digital divide. I mean, the project that we are working on I think we always have this in our DNA and take a look at this, and this is really important.
Thank you very much, all of you. I think at least one message that have come very clear out of this meeting is not surprising, but it's not about whether national public health institutes needs to move in this space, but how and in what direction. And as several of you have pointed out, and you now, Lotta, most clearly, it's the same for IANPHI, I think, and international actors. It's not about whether, but how. And I think we will come back to that also from the European network side and IANPHI. So this is obviously just one early webinar, and I hope that all on the call at least have benefited a bit from sharing ideas here today. And thank you to the speakers, to the Secretariat, to all of you that participated. The recording will be posted together with a summary. And the next webinar, just to mention that in the end, for IANPHI Europe, is about the key strategic choices for national public health institutes in general, where AI technology is one, but of course there are many other pressing questions now that we are in what we call quite tumultuous times. So that will be on November 8th, and all of you are of course very much welcome also to that webinar. So thank you again, and see you next time.